So the next topic is again the reconstruction options for the following the esophagectomy. There are not much controversies on this. It's basically a lot of videos are going to come up in the afternoon. You can see all the options, but just little bit of the theoretical part I would like to discuss here. You can see the videos. A lot of videos are there in the afternoon. So there are not much of controversies in this. We know that it is a surgical challenge because the reconstructions has to be proper because of the leak rates, the stricture rates, and most is because of the leak rates and because of the ischemia and all that. The patient's mortality can go up if there is a ischemia. So we need to have a good functional gastrointestinal conduit for the intestinal continuity. So if you look at what are the reconstructive options, we are going to look at things like what is the choice of the conduit, and what are the routes of reconstruction, and also the level of anastomosis. So these are the three things. Of course, the route of reconstruction, actually there is not much debate on that, because most of the cases in malignancies, we take out the native esophagus, and most of the times it is the posterior mediastinal route that you take. Very, very occasionally, we go with retrosternal or something different. And level of anastomosis naturally depends on what is the surgery that you have done, either McEvans or Ivor Lewis and all that. Based on that, you decide the level of anastomosis. So for having a good conduit, what you need to have is, one is adequate length, because you need to have a conduit which reaches actually up to the neck sometimes, and even the pharynx. And then it should have a good blood supply and reliable and robust blood supply. It's not on the arterial one that is important, but also the venous drainage that is important, because your venous ischemia can cause the necrosis. And the functioning should be ideal. It should function like a normal esophagus. And the other one is that technically it should be easy for everyone to practice. And definitely your choice again depends on the availability of the conduit also, because sometimes you may not have stomach available, and the patient's condition and the expertise that you have. So what are the conduits that are available? One is the stomach, second is the colon, and then the jejunum. But the most commonly used one is the stomach. That is the one that is commonly used. And very, very occasionally, the myocutaneous, fasciocutaneous, and all that are nowadays, we don't see them at all. Only for some corrosive injuries we actually see, but not in the malignancies. Because stomach is preferred, as you know, you can make a good length out of the stomach. And when you mobilize, like when you actually make this, do cauterization, you can get an adequate length even up to the pharynx. And stomach definitely has a robust blood supply, but with some variations you have good functional results, and definitely easy because it's a single anastomosis. But there are situations where you don't have a stomach available, like suppose if there is a tumor extending into the stomach where you need to do esophagogastrectomy, you might not have stomach. Then a previous gastric surgery where you have distorted the anatomy and even the vasculature, sometimes you might have taken like right gastroepiploic. In such cases, you may not have good stomach, and also some previous any corrosives, or sometimes even you have done a previous gastric conduit that is gone and it's not available. So then you have to go for your alternate techniques. So the gastric pedicle, I think you can see how it is made later. But what it is basically is, you look at the all blood supply here. And when you mobilize and make a gastric conduit, it is actually the right gastroepiploic vessel arcade that is going to supply your gastric conduit. But then if you look at this thing, there is, the fundus actually is the area where there is not much of vascularity, because you would have taken even the short gastrics. And this is the area which actually depends on the intramural vascular channels. And you can have some variations in the gastroepiploic arcade also sometimes. And especially sometimes you may not have this complete joining of the right and left. There you have to be a little careful in preserving the momentum in that areas. And also you have some watershed zone between the right and, the greater and lesser curvature. So this is one, when you do this gastric, the most important thing is the vascularity that is important when you do this gastric conduit. So there are studies which have actually looked at the oxygen tension at the tip of the gastric conduit. And when you actually mobilize the stomach and take it into the neck, you look at the oxygen, the tensions actually fall down by almost 50% when compared to the normal. And that can lead to the leak in anastomosis. This again, that depends, the oxygen tension level depends again on length of the conduit, whether there is tension under that. and then the vascular anatomy, how it is, and definitely a surgical handling. If there's a very bad handling or a kink or anything, or tight hiatus, it can actually decrease your oxygen tension there. And we have methods to actually assess that, and the people have shown how they do this ICG, and they can see the vascularity intraoperatively also, and make sure that it's good. It's not only important to see the vascular, the arterial one. You should also look for the venous drainage, the time taken for the enhancement, and again how much time it is taken for the drainage of the ICG. That's all needs to be looked. I think there's a topic on that. They'll discuss regarding that. And there is something called an ischemic preconditioning also for this, but I don't know how many do that. But just at least for mentioning, we are mentioning to that. This is a preconditioning like IPC, where actually they ligate the left gastric artery, and that is done actually sometime before your surgery. Either they do it by embolization or by laparoscopy, they ligate and then leave it for that. But the results, there are some studies which have actually shown the positive results. They have shown that in one study where with the preconditioning, the leak rates have gone down from 20% in without preconditioning and 7% in with the preconditioning.